Okay, this is our second lecture, Quality Improvement for Nursing 300 for Riverside College of Health Careers Professional Nursing Program. The objectives of this lecture are to explore federal and state initiatives aimed at quality improvement in healthcare, explain common methods used to improve the quality of care, identify and explain the steps in quality improvement, investigate strategies that healthcare organizations use to manage risk, apply QSEN and KSA competencies to nursing, investigate the three components of evidence-based practice, explain the benefits of evidence-based care and implications for patient outcomes, contrast differences between a research article and other journal articles, differentiate the 4 steps in developing evidence-based practice, explore the process of change, compare and contrast resistance and driving forces of change, and examine a leadership role in implementing change. History and overview. Starting out as a new nurse can be very challenging. It's important that you not only focus on quality care for your patient, but safety as well as change. Patients place their lives in our hands every day. They expect us to be knowledgeable and trusting while using good judgment whenever we make decisions regarding their care. As nurses, we work within a system, and when there is a breakdown in the system, there is risk for error. History and trends. Decreasing costs while improving patient outcomes influences the current movement toward improved quality and safety. Factors included are economics, societal demographics and diversity, regulation and legislation, technology, healthcare delivery and practice, and environment and globalization. So with economics, something that's been criticized for years in the US by businesses, governments, and the media, the cost of research and development of new treatments and technology continue to rise. What do educated consumers expect? I think we all expect safe, quality care with associated satisfaction and positive health outcomes. Nurses need to be able to support consumers with thorough knowledge of quality, accountability, and cost effectiveness. What does this mean? We must have the knowledge to educate patients regarding technology used in treatments and explain the rationale behind the selected treatment. While initial expense may increase, improvements in quality and safety will reduce costs in long-term care. Societal demographics and diversity. So increased numbers of racial and ethnic groups influence healthcare delivery. Increased numbers in elderly, a longer life expectancy, and improvements in technology result in an emphasis on specialized geriatric care. There are at-risk populations who suffer disadvantages in access to care, payment for care, and quality of care. We all remember the Obama Affordable Health Care Act that was put into place to help minimize the disparities as more of these individuals will have access to healthcare services. If you look at page 255 of Chapter 16, it contains more information about the Affordable Care Act and major provisions. Regulation and legislation. The diverse interest of consumers, insurance companies, government, and regulation affect healthcare legislation. The Affordable Health Care Act now provides healthcare to individuals who previously lacked coverage. This access to healthcare will increase the numbers of individuals who will need providers, as well as force changes in regulation and cost management. Technology. The use of technology and incorporation of electronic healthcare records are projected to decrease costs and improve clinical outcomes, quality, and safety. Nurses must utilize technology and informatics to incorporate evidence-based practice for improved quality and safety in the healthcare delivery system. With technology, we have advancement in disease treatments, especially genetics. Healthcare delivery and practice. Be prepared to provide safe and quality care in all settings, which includes acute care and community care settings. We must have knowledge, skills, attitudes, and competencies to function in a variety of settings, and the ability to support the needs of the increasingly diverse population. With the integration of evidence-based practice, we improve quality and safety for patients and improve collaboration and interprofessional teamwork. Environment and globalization. Global warming and climate change have been linked to the emergence of new drug-resistant organisms and an increase in vector-borne and waterborne disease, as warmer temperatures promote changes in organism structure and increase the growth rate of bacteria. The Institute of Medicine is a private nonprofit U.S. government organization to provide unbiased scientific advice for improving health. They list the characteristics of quality healthcare as safe, avoiding injuries to patients from the care that is intended to help them; effective, providing services based on effective knowledge and refraining on scientific knowledge and refraining from providing services to those not likely to benefit, essentially avoiding underuse and overuse. It's patient-centered, providing care that is respectful and responsive to patient preferences, needs, and values; timely, reducing waits and sometimes harmful delays; efficient, avoiding waste, in particular that of equipment, supplies, ideas, and energy; and it's equitable, providing care that does not have any quality variations. The IOM also concludes that quality can be defined and measured. Quality problems are serious and extensive. Current approaches to quality improvement are inadequate. There is an urgent need for rapid change. The IOM's scientific studies and work has led to a series of reports that serve as the foundation for efforts to improve the quality of healthcare provided in the United States. Two reports in particular are the To Err is Human, Building a Safer Health System, and Crossing the Quality Chasms, A New Health System for the 21st Century. These both provide a framework upon which the 21st century healthcare system is being built. We will look into both of these studies in detail in future slides. The IOM essential competencies necessary to move healthcare into the 21st century are employing the use of evidence-based practice, providing client-centered care, and utilizing informatics. So the Institute of Medicine, the IOM, had a 2000 report, year 2000 report, To Err is Human, Building a Safer Health System, which concluded that 98,000 deaths in the hospitals each year resulted from preventable medical mistakes. The report was stimulated by the Presidential Advisory Commission on Consumer Protection and Quality in the Healthcare Industry. It also concluded the current system is fragmented and poorly organized. This IOM study quantifies unnecessary deaths in the U.S. healthcare system and places emphasis on system failures as the foundation for errors and mistakes. The IOM report relied on a study to categorize types of errors completed by Leap, Bates, and Patricky in 1993. The study found that 70% of all errors were preventable. The types of errors categorized included a near miss, which can also be called a good catch and is an error or mishap that results in no harms or very minimal patient harm; or an adverse event, which is an event that injures the patient and was caused by the care provider rather than an underlying condition of the patient. Also completed by the IOM, the Committee on the Quality of Healthcare in America 2001 report, Crossing the Quality Chasm. It focused on developing new healthcare systems that improve health. It found healthcare providers are unable to keep up with rapid changes in technology. Chronic diseases are now the leading cause of illness, disability, and health problems. It affects almost half of the U.S. population. The current system is complex, fragmented, and disorganized. This figure lists areas to focus on based on the study findings of Crossing the Quality Chasm, A New Health System for the 21st Century. They identified 6 aims for improving the healthcare system. These include safe, effective, client-centered, timely, efficient, and equitable. Ten rules to govern healthcare reform for the 21st century. Care is based on a continuous healing relationship. Care is provided based on patient needs and values. The patient is the source of control of care. Knowledge is shared and free-flowing. Decisions are evidence-based. Safety as a system property. Transparency is necessary. Secrecy is harmful. Anticipate patient needs. Waste is continually decreased. Cooperation between healthcare providers. Healthcare organizations are expected to have QI programs, quality improvement programs, that promote QI strategies and an overarching plan that serves as a roadmap for high quality care and service. So, what is quality? The Institute of Medicine's IOM 2001 definition of quality is the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. High quality care involves providing patients with appropriate services in a technically competent manner with good communication, shared decision making, and cultural sensitivity. View the definitions listed in the above figure to identify the difference between research, evidence based practice, and quality improvement. How can nurses provide high quality care? What is quality improvement and continuous quality improvement? Answer: by participating in quality improvement. Be a change agent. Change agents do not wait for change, they look for it and embrace it. Florence Nightingale evaluated the care of the soldiers during the Crimean War. She found filthy conditions, bugs, lice, and soldiers dying of diseases as a result of the conditions. She bought clean linens, food, utensils, etc. to aid in the healing of the soldiers. She felt that diet, dirt, and drains were main problems. She studied the conditions and changed the way care is being delivered to the soldiers. Quality improvement, or QI, usually involves the following common characteristics: a link to key elements of the organization's strategic plan, a quality council consisting of the institution's top leadership, training programs for all levels, mechanisms for selecting improvement opportunities, formation of process improvement teams, staff support for process analysis and redesign, personnel policies that motivate and support staff participation in process improvement. CQI, or quality assurance, involves identifying the areas of concern, continuously collecting data on the areas of concern or indicators, analyzing and evaluating the data, implementing needed changes. An example of areas to focus on for a CQI, or quality assurance, include: is the medication always available at the right time, right dose, or do you have to wait for pharmacy to bring it? Is the pharmacy tech delayed by emergency orders? They look at the entire process and map it out. What can you do by next Tuesday? Or what can you plan to improve by the end of the semester? So the IHI Institute, the Health Institute, collaborated with a gentleman named Dr. Mike Evans, an associate professor of family medicine and public health at the University of Toronto, to create a dynamic animated whiteboard video that introduces the concepts of quality improvement in healthcare. Dr. Evans has become well known in healthcare circles for his fast-paced videos that have attracted millions of views on YouTube. In the video, Evans starts with a simple question: why should you care about quality improvement? He presents a brief history of QI, including Mount Rushmore of improvers, then touches on system design, the model for improvement, and the familiar challenge: what can you do by next Tuesday? All in less than 9 minutes. Take the time to click on the link provided in the slide and watch the video. Quality at the organizational and unit levels. So there's strategic planning, which includes a strategic plan, which is a short visionary conceptual document that serves as a framework for decisions or for securing support or approval. It provides a basis for more detailed planning, explains the business to others in order to inform, motivate, and involve, assists benchmarking and performance monitoring, stimulates change, and becomes the building block for the next plan. During the strategic planning process, the organization develops or reviews its vision, mission, statement, and corporate values. They also review and identify, with help from the team, strengths, weaknesses, opportunities, and threats, or SWOT, SWOT. Structural care methodologies are interprofessional tools that are used to identify the best practice and facilitate standardization of care. There's tools for tracking outcomes. They have clinical practice guidelines, which are based on current research strategies and are often developed in the field. It is seen as a way to decrease variations in practice. There's also protocols, which are specific and formal documents that outline how a procedure or intervention should be conducted, a way to standardize approaches to achieve desired outcomes. Examples would be our chest pain protocol in the ER or the stroke protocol. There's algorithms, which are systematic procedures that follow a logical progression based on additional information or patient response to a treatment. Consider ACLS. Standards of care is discipline related and helps to operationalize patient care processes and provides a baseline for quality of care. Lawyers refer to these to see if a patient received appropriate services. Critical clinical pathways help to outline the expected course of treatment for patients who have similar diagnoses. To begin QI, an individual, unit, or facility must understand its baseline performance. Intradisciplinary assessment occurs within a group of individuals who have similar positions. Peer review is used to professionally critique a colleague's work based on predetermined standards. There's audits, which is an examination of records to verify accuracy and proper use. There's a retrospective audit, which is performed after a client's discharge. Concurrent audits, which are performed while the client is still undergoing care. There's outcomes management, which uses client experience to guide improvement in all areas of healthcare. Collaboration between a variety of disciplines. So utilization review analyzes the use of resources to identify overuse, misuse, or underuse. It's required by Medicaid for specific services, and it's also required by the Joint Commission for facility accreditation. There's also benchmarking. It is a method used to compare the performance of an individual or organization to industry standards. Standards of care are based on established models of high-quality performance and may reflect the performance of industry leaders, scientific or clinical research, or recommendations of professional organizations such as the ANA, or the American Nurses Association. It also uses indicators. It compares organizations' performance and specific indicators against industry standards. So the indicators must be measurable, objective, and sensitive to changes in performance. They can include generic or specific standards of care specified by professional organization or by areas implementing quality improvement strategies, such as your facility or unit. So then we worry about sentinel events, which question is, what is a sentinel event? The answer, as defined by the Joint Commission, is an unexpected occurrence involving death or serious physical or psychological injury, or the risk thereof. It requires immediate investigation to include a root cause analysis and a response. So, evaluation of healthcare. It has structure, which refers to the setting in which the care is given and to the resources that are available. There are facilities, comfort, convenience of layout, the accessibility of support services, and safety. There's the equipment. Are there adequate supplies? Is it state-of-the-art equipment? Are staff able to use the equipment? How is the staff? Credentials, experience, absenteeism, turnover rate, staff-patient ratios. And then finances. How are the salaries? Is it adequate? How are the resources you have? There's the process, which refers to the activities carried out by the healthcare providers and all the decisions made while a patient is interacting with the organization. Examples: setting an appointment, conducting a physical assessment, ordering an x-ray, MRI, or labs, administering a blood transfusion, completing a home environment assessment, preparing the patient for discharge, telephoning the patient post-discharge. Outcomes: the result of all the healthcare providers' activities. The outcome questions asked during evaluation should measure observable behavior such as the following: patient, wound healed, blood pressure within normal limits, infection absent. Family, increased time between visits to the ED, applied for food stamps. Team, decisions reached by consensus, attendance at meetings by all team members. So root cause analysis determines what influenced the consequences, establishes tightly linked chains of influence. It's at every level of analysis to determine the necessary and sufficient influences. Whenever feasible, you drill down to the root causes and know that there are always multiple root causes. Risk management addresses real and potential hazards in an organization. There's a service occurrence, which is an unexpected occurrence that does not result in a clinically significant interruption of services, and that is without apparent patient and employee injury. Examples would be minor property or equipment damage, unsatisfactory provision of service at any level, or inconsequential interruption of service. Most occurrences in this category are addressed within the patient complaint process. There's the serious error incident, which results in a clinically significant interruption of therapy or service, a minor injury to a patient or employee, or significant loss or damage of equipment or property. Minor injuries are usually defined as needing medical intervention outside of hospital admission, or physical or psychological damage. Sentinel events is an unexpected occurrence involving death or serious permanent physical or psychological injury or risk thereof. These events signal the need for immediate investigation and response. When this type of event occurs, certain people within the organization must be made aware of the event. They must investigate and understand the causes of the event and make changes in the organization's systems and processes to reduce the probability of such an event in the future. Suicide, fall resulting in a death, blood transfusion reactions, timeout for surgery, and infant abduction are all examples of a sentinel event. Nursing shortage and patient safety. So what are some of the causes of nursing shortages? There's increased demand for nurses, a reduction in and shortage of nursing faculty, job dissatisfaction. According to the ANA, more than 60% of nurses graduate initially from associate degree nursing programs. Developing a culture of safety. Who drives this? Senior leadership and the organization. A blame-free environment in which reporting of errors is promoted and rewarded. A culture of safety promotes trust, honesty, openness, and transparency. Teamwork and involvement of the patient contribute to promoting a culture of safety. Reporting errors, providing data, and the necessary information to determine why or how the error occurred, thus improving and preventing care and harm. Thus improving care and preventing harm. R-CARE, which the FDA mandates reporting of serious harm or death, adverse events related to drugs and medical devices. Failure to report mandatory requirements may lead to fines, withdrawal of participation in clinical trials, or loss of a license to operate. So, federal initiatives to improve quality. The U.S. Department of Human Health and Services published National Strategy for Quality Healthcare in 2011 based on 3 aims. Better care, improve overall quality by making healthcare more client-centered, reliable, accessible, and safe. There's healthy people, healthy communities, which is to improve the health of the U.S. population by supporting proven interventions to address behavioral, social, and environmental determinants of health in addition to delivering higher quality care. There's also affordable care, which is reducing the cost of quality health care for individuals, families, employers, and the government. So there are developed indicators of high quality care and measures. So there's also something called the HRSA, that's Health Resources and Services Administration, which there's health centers that care for everyone, even if you have no health insurance. You pay what you can afford based on your income. These health centers provide services that include checkups when you are well, treatment when you're sick, complete care when you're pregnant, and immunizations and checkups for your children. Some health centers also provide mental health, substance abuse, oral health, and or vision services. Just contact the local health center organization directly to confirm the availability of specific services and to make an appointment. So, what has the economic climate in healthcare pressured providers into delivering quality care at a lower cost? There's an economic perspective, regulation and competition, along with the nursing labor market. So, factors influencing the economic climate include, of course, the economy, regulations, competition, and the nursing labor market. States do have local initiatives and are partially responsible for providing state health insurance for low-income individuals and families. There are basic health plans available, including state-funded Medicaid plans and community health centers that can be either federally or state-funded. So safety in the U.S. healthcare system focuses on several different factors, including the types of errors, error identification and reporting, developing a culture of safety, and utilizing organizations, agencies, and initiatives to support quality and safety within individual healthcare systems. Organizational initiatives to improve quality. There's risk management, which we talked a little bit about before. So healthcare organizations usually have a risk manager who ensures that adverse events, errors, and safety issues are investigated and reported. Error identification and risk events are categorized based on the severity. There's a service occurrence, minor injuries, a serious incident, a sentinel event, or never events. So a near miss results in no harm or minimal harm to the patient, which we talked about, catching a med error before it's administered, and then the adverse events, which are injuries to a patient caused by medical management rather than underlying conditions of the patient. Many are preventable. See box 11-2 on page 165. There's 4 types of adverse events, which are diagnostic, treatment, preventive, and other. Causes and common risks for errors include medication errors, which are preventable accidents that occur during the medication process that could or did lead to patient harm, errors in patient safety that result in falls, failure to communicate, failure to perform nursing care treatments correctly, diagnostic and surgical errors, healthcare acquired infections, documentation errors, or omissions. Nurses are on the front line for identifying and reporting errors. Why would nurses not want to report an error? Well, there's consequences. Some organizations or providers fear blame or punishment. There's lawsuits. The culture of blame prevents or discourages individuals from coming forward. So the Joint Commission has national patient safety goals for 2018. There's the NDNQI indicators, which were developed by American Nurses Association in 1998. It does provide important statistical, valid, and reliable data. Data may be used by organizations to improve client care. Data may also be used to identify relationships between nursing staffing levels and client outcomes. There's also Press Ganey, which is surveys that are handed out to or mailed to patients who are discharged, and it's randomly mailed, which Press Ganey says that their mission is to help healthcare organizations reduce patient suffering and enhance caregiver resilience to improve the safety, quality, and experience of care. So the NDNQI, which is the National Database of Nursing Quality Indicators, is the leading quality improvement and nurse engagement tool in the U.S. It was developed again by the ANA and recently acquired by Press Ganey. It is a proprietary database that collects and evaluates unit-specific nurse-sensitive data from acute care hospitals, providing healthcare organizations with unit-level comparative data reports. It helps to improve nurse retention, nurse engagement, and promotes nursing excellence. As the largest provider of unit-level performance data to hospitals, the NDNQI is currently in use in more than 2,000 hospitals across the country. When coupled with Press Ganey's deep benchmarking data, innovative engagement tools, and advanced analytics, NDNQI can play a critical role in helping to transform healthcare organizations, enhancing the patient experience, and improving the quality of care. All right, moving on. We know there is a problem. The QI process is a continuous, multi-step, multi-level process that identifies areas for improvement based on performance and industry standards. The QI process analyzes current protocols of care and outcomes, compares against gold standard outcomes, which are benchmarking, identifies areas for improvement, researches factors that contribute to better outcomes, implements changes to improve outcomes. So what I'd like for you to do at this time is to take 10 minutes and write down some nursing problems you have seen in healthcare. Okay, so what do we do now after there's a problem? All right. We should develop a plan. Continuous quality improvement. It's a structured organizational process for involving personnel in planning and executing a continuous flow of improvements to provide quality healthcare that meets or exceeds expectations. Can be applied to a specific problem, development and implementation of policies and procedures, resource utilization, or implementation of evidence-based practice. System-focused, customer-driven process. There's internal and external customers involved. There's something called the Six Sigma too, which the goal is to reduce variations within a process to produce a near perfect product. Was originally implemented by Motorola and General Electric. Sigma, the Greek letter used to measure deviation from a standard, i.e. to receive a 6, only 3.4 products per million are allowed to be defective, and a defect equals anything that could lead to client dissatisfaction. So it involves to define the problem, determine a goal, and form a team. Measure to obtain data related to the current process, the problem, and the desired goal. To analyze, look at the data to determine cause and effect relationships related to the problem. To improve, develop solutions to problems and implement those solutions. To control, implement measures to sustain positive changes and continuously monitor the process to ensure goals are being met. With Lean Six Sigma, methodology to reduce waste and provide consistency and the quality of care is the focus. You can combine Six Sigma with the Lean system, which the Lean system objective is to eliminate waste and maximize value. It primarily uses DMAIC. So there's the comprehensive management philosophy, which was invented by Walter Sheward, made famous by W. Edwards Deming. It was used to improve quality and productivity by utilizing data and statistics to improve quality and productivity. The hallmark is organizational teamwork, so it involves all departments and employees, suppliers, and customers. And essential elements are communication, feedback, fact-based decision-making, and they focus on continually improving. There are several phases. There's the plan phase, where individuals define the goal, they collect data, and outline a strategy to reach the goal. There's the do phase, where they plan, implementation on a small scale to determine effectiveness. And then there's the study phase, where outcomes of the do phase are analyzed and compared against expected outcomes. And then the act phase, where the team must decide if the goal was met, plan further changes, decide if the original goal was attainable based on the results. And if the goal was met, they need to decide if changes should be implemented organization-wide. So what is evidence-based practice? What is evidence? Clinical knowledge, an expert opinion, or information resulting from research. Sigma Theta Tau International Honor Society of Nursing's position statement on evidence-based nursing is an integration of the best evidence available, nursing expertise, and the values and preferences of the individuals, families, and communities who are served. This approach to nursing care bridges the gap between the best evidence available and the most appropriate nursing care of individuals, groups, and populations with varied needs. It's generally composed of 3 components: best evidence from most current research available, nurses' clinical expertise, patients' preferences reflecting values, needs, interests, and choices. It's used to close the gap between the actual practice of nursing and research, a formal, systematic way of answering a question or approaching a problem in areas that are of interest to nursing. Evidence is a product of research. Benefits of evidence-based practice. In evidence-based practice, nurses use research from a variety of sources and disciplines to guide and validate their clinical practice and improve client care. They ensure the credibility of their profession. It provides accountability for nursing care. And there's translational research, which is the emerging as a systematic approach of converting research knowledge into application of healthcare. So, barriers to evidence-based practice is there's limited knowledge and skills for finding and evaluating evidence. There's a lack of experience or confidence in development of strategies for evidence-based practice, lack of support from supervisors or facility team members, a lack of access to continuing education programs, a resistance to change from traditional patient care routines, and then there's developing evidence-based practice. You can see here, step 1 is develop a clinical question. Step 2 is retrieve the evidence. Step 3, evaluate the evidence. And step 4 is apply the evidence. And that all funnels down to evidence-based practice. So key questions to ask yourself are, what are we trying to accomplish? Is the change necessary? Is the change technically correct? Will it work? Is the change a better way to do things? So PICOT stands for the 5 elements of a clinical question. P for population of patients, I for issue of interest, C for comparison of interventions, and O for outcomes, T for time frame. Step 2, retrieve the evidence. During literature reviews for evidence-based practice, seek out scientific merits in each journal article to ensure it is a professional research article. How will you know it's a research article? Take 10 minutes and find a research article. Pause if you'd like. Okay, continuing on. So table 45-3, page 2590, which will provide these resources for you and references. So it's something to refer to in regards to the order of sections typically found in a professional research article. So you have the title, which gives the main topic of the research study. There's the abstract, which provides a summary of the entire content of the journal. The abstract is usually what I will review to make sure this is something that I want to read further and is applicable to what I'm researching. The introduction presents the question or focus of the investigative study, includes a background of older research on the same hypotheses, the study that was conducted, describes in details what was done, the results of the study, reports all the data, And then there's the conclusion, which summarizes and interprets all of the data, the study, and the hypotheses, evaluates its findings. And then you have the list of references at the end. So nursing clinical research, as out text states in a very broad definition, research is obtaining information and objective facts to advance knowledge about a specific topic. Nursing clinical research is focused on obtaining information to advance knowledge regarding a specific topic with the goal of prevention and health promotion. Nursing clinical research seeks answers to key questions to improve patient care. Implications in nursing practice. So, what are the three major benefits of nursing clinical research? Provide best evidence for evidence-based practice, support nursing as a separate professional discipline, define current best practice standards of nursing care. But not all research is created equal. You want to evaluate the evidence. Evidence must be critically appraised for validity. Did the study measure what it was intended to measure? Is it reliable? Did it have the ability to produce consistent results with each use? And also usefulness. Evidence can be applied to clinical practice. Nurses must be able to critique research articles in journals to identify the strengths and weaknesses of the study and the resulting evidence. Step 4 is apply the evidence. So nurses must analyze collected data and decide to accept, reject, or modify the change to clinical practice. If change benefits patients, nurses can recommend new clinical practice, and it can become a standard of care in the facility. New evidence would replace older evidence. It's an ongoing process too. Why? Again, because new evidence replaces older evidence. Change, in case you need to write that down. Okay, change, which is chapter 10. We'll go ahead and get started on that. So, perceptions of change. What do you think of change? It's a natural phenomenon. There's macro and micro change. So the macro level change is the large scale where changes affect healthcare. It's large, and each healthcare organization, it affects them constantly. A micro level is on the small scale of change. So when changes occur in a system, there's ripple effects to nursing units and team members. The impact of change, it can be local, confined to one nursing unit or organization wide. It may be small or sweeping, and it also may occur gradually or rapidly. So the change process has 3 basic stages, which are described by Kurt Lewin in 1951. And these are unfreezing, which is comfort zone. It involves actions that create readiness to change. And then during change is the discomfort zone, which is the implementation phase. It's the actions needed to put the change into effect. And then in refreezing, it's the new comfort zone. It reestablishes what the change is, what was made, and it becomes a regular part of everyday functions. The refreezing phase ensures that team members have moved to a new comfort zone. Key questions to ask yourself: is the change well integrated into day-to-day operations and routines? Is it working well for team members? Are team members comfortable with this change? Is this change well accepted? Is there any residual resistance that may undermine what you have implemented? So, receptivity to change. There's a preference for certainty, which means you're helping teams recognize their preference for certainty or proven approaches as opposed to change will increase their receptivity to necessary changes in the workplace. You also should speak to people's feelings. Tell a compelling story surrounding the reason for change. This will increase receptivity to change more than a carefully crafted analysis of the need for change. There is more sense of urgency. Resistance to change. Why do we not want to change? If it's not broken, why fix it? Ain't nobody got time for that. Try to figure out my computer here. It's decided to quit. Lack of input or participation. It may create more problems than it solves. There might be some sources of resistance, such as technical concerns, personal needs, or position and power.